Thank you, Volker. Good afternoon. It's an honor to be here, and I really like the invitation to be here and to have a talk with you about, well, what I'm working on for the last 10, 15 years on population health management. Why are we working? Why am I'm invited here right now? I think if you look at what is going on, population health management has gained momentum globally. If you look at market shares in the economic world and they count how much money goes on in population health management initiatives, etc., you see an enormous growth. I think the Affordable Care Act in the US has made a huge impact over there that people now are working with population health management. The UK has, as you heard this morning from the NHS, especially in primary care, population health management is one of the big topics over there. But also if you look at countries like India, Singapore, we've just been to Australia, the topic gains momentum worldwide. So I think it's important that we understand what it is, why we're doing it. Is it different? Is it not different? Is it similar? Is it, I don't know what. We are going to talk about that in a little. This is what I'm going to talk with you for the next 20 minutes. Make up your mind. It's about you. I know what I'm going to tell. I'm always told to say to my students, I know exactly what's on my next slide. But you have to, in fact, make up your mind after this half an hour. What do you think of population health management? So, to start off, I would like you, and you're sitting a little bit too much fragmented, like the healthcare system. But say to somebody close by to you, what do you think are the essentials of population health management? For 20 seconds. Just, that's a didactic trick, to open up your mind and let all the other stuff go. So talk with somebody close by, please do, for 20 seconds. And what do you think population health management is about? Ja, das geht besser. Das ist besser. Okay, I hope after this talk I have shown you the rationale of population health management, the definitions, differences with other concepts. Is it different? It is a little bit, but not that much. It has some essentials that it makes a distinction with other concepts. Some examples, and the biggest challenge is how to implement. As Volker already said, our chair, about, how do we really get that strategy into place, that it works, that the population and the people we care for, we do it for, really feel that their health is improved. Okay, let's go back a little bit. The rationale of population health management. I think the uptake, again, because it's an old concept, it was already there in the 70s of the previous century, but the uptake came again, I think, through a famous paper by Donald Berwick about the triple aim, which he introduced in 2008, in which he claims that you should go in your healthcare system for 3 aims simultaneously: improve patient experience at an individual level, population health at a population level, and per capita cost at a lifetime personal level. So you should try to reach those 3 dimensions of one aim. I never say 3 aims because it's a triple aim. The triple aim, if you want to reach that, you have to think about population health management. You have to start thinking about populations. because a single disease is not what is going on in a population. One condition is not what counts in a population. In a population, it counts multimorbidity, multiple problems. You need to have a population focus if you want to reach that triple aim. You have to include then, and we know that because more than 80% or 90%, figures differ a little bit, of the influences of what causes health problems in individuals comes from outside of our sphere of influence, comes from social factors, comes from physical environment, maybe a little part from genetics as well, but the social context and the physical environment is much more important. If you look now in the current literature, you see the concept of syndemics coming in. And the syndemic is nothing more or less than the interaction of two diseases in a similar person that progresses differently in different socioeconomic circumstances. And you can imagine, I'm a wealthy man, I have a high blood pressure, and if I start to have something like diabetes, my progression is completely different from, and I know I'm a lot criticized because of this comparison, but if Ali is there, he's also 58 years of age, he has also 3 children, he has also a high blood pressure, but if he gets diabetes, we saw this morning, his life expectancy is completely different. And we have to take that into account if we start working on population health. It's not that easy to get me over the age of 90 in my life expectancy. But it's much more difficult to get him over the age of 80 for his life expectancy. Those are political choices, I know. But that's what the population focus is about. That's why syndemics is rising. The other rationale is the toxic collaboration, I call it, which we have within healthcare. And that's beautifully illustrated by the tragedy of the commons, which is an economic principle from Isaiah Berlin from the 19th century, in which we say that we organize healthcare in such a way that every actor is rationally behaving to get his best interests for his part of the pie, and we incentivize everybody also that way, and nobody is taking care of the whole pie. And because of that, we lose. Everybody loses in the end. So if we start working like the tragedy of the commons continues, if we continue working like the tragedy of the commons, then in the end, we all lose. And we saw this morning, health expenditure, health spending is, we need even more money than we can earn with each other if we look at the aging of the population. I don't know else. We have to do something differently. So that toxic collaboration, which is now there, and we're all part of it. I'm also part of it, I know. So it starts with that I start looking differently. Okay, that's the rationale why we have to look at the population as a whole and not at specific parts of that what we are working at. Well, WHO luckily also thinks that's a way of looking. And together with colleagues, we made a policy paper in which we say, okay, we need 4 types of transition. From a one-size-fits-all to a tailor to the need. From passive and reactive to proactive and anticipatory. So we don't wait until a patient shows up in our surgery room, but we already know, and AI has huge opportunities over there. We already know what is going on then. From a biomedically focus, and I know it's I work at Leiden University Medical Center, so I have a lot of colleagues who are specializing in the smallest part of the body, and I think they still should do it, but that's not the focus if you look at population health management. Do a greater focus on psychosocial and social determinants of health as well. I said it already, we are fragmented. So we need to go from fragmentation to coordination and integration. Those are the transitions we are looking at. Primary care plays a crucial and a pivotal role over there. That's the place where everything comes together. So if you, and we heard it this morning as well, a strong focus on primary care is needed. And if I look at countries like Mexico and Korea, etc., what are they doing? Their health systems, their hospital systems, they are transforming it to community care systems as well. So as a hospital system, they take up the obligation and the responsibility to realize also a very tight primary care network around their systems, within their systems. Okay, that's what is why we are doing it and what's the way we are moving. What is it then that we do in population health management? It's not that difficult. It's so logic if you start thinking about it. We follow a cycle. We start by the one where we say, okay, there's a population definition and there's identification. We know what is going on in that population. We know which population we are focusing on, the elderly, people in a deprived neighborhood, people with some kind of disease even, if you like. I'm not fond of that, but people do it. We identify. We look in that population, we put the health assessment, we perform a health assessment, and we segment that population towards their burning platforms. What is really going on in your group, in your deprived neighborhood? What are the main problems you have to address? Guess, if I go to a deprived neighborhood here in Berlin, what are the problems that the people say that you need to address and what comes out of the numbers? And are those the problems that you address with your health system? And we did it in one of the neighborhoods in The Hague. It was safety. That their children could go out after dark, out on the street and walk safely, that their daughters were not attacked and stuff like that, because that raised an enormous amount of mental health problems. It was safety. Okay, we spent 3% of our healthcare budget on prevention. Okay, I'm a believer, I must say. So we segment our population. Then we risk stratify. What is risk stratification? We just look at which individuals can we target, naming who are the individuals with the highest risk that we need to target, to tackle. In the Netherlands, and I think you have that in Germany as well, we have a bonus card, a card from the groceries that you use if you buy, and then you get your bonus, you get your discounts, etc. Why do they do that? Which healthcare facility has a bonus card? Why do they do it? Because they want to target you with the right advertisements, and they want to know where to put what in their store so that they can make more money out of your pocket. Why don't we use that for health? We have the opportunity. This morning, from the OECD, the woman said, how much information is there? We don't use it. And we have it. We have it within healthcare. Yeah, sure, it's fragmented. Sure, you cannot link it. And sure, we have privacy problems. Sure, it's all true. But that doesn't give you the way out. You still can use it. Okay, stratification, impactability modeling. That means which population are we going to have the highest impact? So not only who has the highest risk, but also where do we have the highest impact? That's impactability modeling. Then we have in that population the service that is needed. So, and I really like the slide about the diabetes management program this morning, and then I thought, okay, that's what we did 15 years ago. That was a one-size-fits-all, and everybody got the same diabetes management program within primary care. Now we are going to the next phase. I don't say that was wrong. That was in that time and place absolutely right, the right thing to do. And now we move on. We need a different scheme in the private neighborhoods where the Alis live of 58 years of age than myself in a very affluent city, village, I must say, Wassenaar near the coast, and where the king lived and stuff like that, very affluent. We need a different scheme. We do need it. So please start working on it. And then, most important, evaluation and improvement. It is a learning system. It is a learning approach. It's not just, and I come back to that later, Volker, an economic model that we target the right population and we can make the most health out of there. Yeah, probably not make the most money out of there, but make the most health there. And that may cost a little bit. But then we have to learn from it. We have to move on the cycle and see in our data again, are we succeeding? This, in essence, is the narrow population health management approach. Not more, not less. The narrow one. Because, I put nice there, what you should remember from this slide. Optimal targeting, the population with the highest expected impact, and continuous evaluation. I think those are essentials of population health management that you don't see that often in the other concepts. Oh, there it is. Oh, that went wrong. And then if we have that cycle, population health management small, and we need to transform it, or to implement it in a health system, we need to have the population health management approach at large. And now there are a lot of things that you all recognize that are in managed care, that are in integrated care, that are in other concepts as well. We need accountable regional organizations. We searched literature, we did Delphi rounds, we put it into practice, and we came up with a maturity index, which consists of 6 different elements. And Victoria Stein, she's here, she worked with us on that in that matter. We came up with 6 different elements over there. An accountable regional organization. We need a cross-domain business model. Yeah, we need to work together in our business model. We have to open up and show our facts and figures to our colleagues who are now still our competitors. And we need to work together and see how we get it going there. Otherwise, you don't do population health management, you do something different. We need an integrated data infrastructure, although I'm working now with a PhD who is looking at what kind of infrastructure do you really need. We are not that convinced that you need all the linkage that we're talking about right now. We're not convinced yet. Because we see that with the fragmented data infrastructure, we also can do very much. And what's then the added value of putting an enormous amount of effort in privacy and open up all your information systems and link them, and costs a lot of money and time and energy and frustration? Well, we can start already working on stuff. Okay. It's still there. Co-designing workforce and community, we heard it this morning as well. You need that part. What matters to, I didn't know, I noticed it on the slide of the woman from the OECD, I forgot her name. But she said, what matters to the patient? That sounds different than what matters to you. To the patient is externalizing. What matters to you is internalizing. Maureen Bisignano from the IHI introduced the what matters to you very profoundly, and she said always what matters to you. Ask your patients what matters to you. Ask your inhabitants in a region what matters to you. Not come with facts and figures. This is what matters to the patient. You have that, but you combine it together with what matters to you. That's co-designing workforce and community, also with the professionals. Because what you say is right. Also in the Netherlands, the professionals, though the figures are not always right. So it shows a little bit better in Holland, but it is not. The workforce is complaining, and I think they're right, like hell. We need data analytics. There's a lot going on there. A lot of companies are working on stratification models, on all kind of stuff, often disease specific, to work with population health data analytics. And we need an emergent implementation strategy. So we need to go with the flow and find our way in a region, in a population. Where is the energy? Build upon that energy, move further from that energy, and try to align all the different initiatives which are there in a region, because there are a lot of initiatives on obesity for children and on the 10 different initiatives next to each other, and they don't know from each other that they are there. And then you have to align them in a way that they work together. That's emergent implementation strategy, also together with obesity clinics that hospitals think we need and stuff like that. We brought that together, so the inner circle is the population health management cycle, the narrow view, and around that we say you need all those elements to implement it. So if you implement this slide, then you're doing something what we can call population health management. Okay, what about the other concepts? Now you know what population health management is. I start talking a little bit about 3 other concepts and compare them. And you may disagree with me. On that first part, I think I'm quite, okay, that's population health management. On this part, let's discuss. If I look at value-based healthcare, I would say Michael Porter, you know, and Elizabeth Thijsberg, and the whole world that was coming from there, it's more an economic-driven approach. They start always with a population, with a condition. A group of people, they have something. Whereas in population health management, we just start with the population and start looking what is going on. So in fact, if you start there, they can include value-based healthcare, can be part of population health management for specific subgroups. Often, value-based healthcare is directed at single interventions or at a bundle of interventions for that specific condition, whereas population health management looks at also the social determinants of health and the syndemics part of it. The third bullet shows the triple aim versus outcomes divided by cost. Outcomes divided by cost is the traditional value equation coming from value-based healthcare. Population health management looks at simultaneously triple aim, is much more fluid. You can't calculated in a way. I just wrote a paper again about how do we balance those three aspects of the triple aim? How do we balance it? Can we come to one closure? No, was the answer. We have health improvement versus care optimization. In my opinion, integrated practice units in value-based healthcare are trying to do the most efficient way of care delivery as possible for those patients with a specific condition. Are they really looking at health improvement? Only for that small specific condition. Whereas the health of a patient, of a person, is much broader. And the last one is tricky, but it is there, the societal versus the profitable aim you want to focus. Michael Porter says, by 5, expand excellence services across geography. So if you have excellent services, do it in the other region, and do it in the other region, and do it in the other region. And we have, and you will have that as well, we have those Bergman clinics. They are all doing the knee surgeries and the eye, the star, and that's, I don't know what it is in English, but the star operaties. And you know, they expand geographically, but they take out the cherry, they do cherry picking in the population. And that's not bad, as long as they are part of the whole infrastructure for that population. And as long as they go for their own profit, they stay within the tragedy of the commons. That's my point of view. Okay, that's value-based healthcare. Managed care. I'm not an expert on managed care. You are, but what I understand from it, managed care is more about cost containment, improved productivity and resource utilization through structures and contracts. And in fact, the focus is on how do we organize the system with the key players to reach that goal, but not the health of the population. Because then you have other players that come into play as well, where you have to organize with. So yeah, managed care can be a very strong push for population health management if you organize it in the way of the AAA. Integrated care, well, there's the rainbow model of integrated care that we developed a couple of years ago. I don't know where integrated care really focuses at. I think it's more of a process of coordination and optimization of services that the patient experiences a seamless, fluent, a bundle of services for their problem. I think that's what integrated care is doing. I think that's very, very valuable. But I don't know, and I know Victoria is not on my side there, but I don't think that integrated care is really looking at the beginning at the patient needs in the way that we should look at patient needs. And can be much more data-driven than they are right now. I don't see things like risk stratification. I don't see things like impactability modeling within integrated care services right now. Are they wrong? No, they're not. But we have to move on with each other. We have to incorporate all the different concepts together. But if you say, I'm doing integrated care, so I'm also part of the population health management family, then I say, okay, but you still have to learn a little bit more about risk stratification and impactability modeling, because I don't see that yet in your structures. Stuff like that. You can turn it around as well. Eh? But in the end, the essentials of population health management, it has a population focus and looks at the differences within that population. It's data-driven, it has segmentation, stratification, impactability. It looks at all influences on population health, also outside of the medical domain, please take notice of the emerging field of syndemics. It is really going to change our lives. And I think it's going to change medicine as well. The real syndemic part behind it. Because it says diseases do not progress equally and similarly in bodies. Because you see differences between populations. And that is something that medicine has to take into account in the end. I don't win this argument yet within our own Leiden University Medical Center at all. So I know. What matters to you, not what matters to the patient, but what matters to you. Really go out there, go and talk with the people, sit next to them, ask them what matters to them, and start building your interventions and your impact on that. And embrace the complexity. I didn't talk about complexity yet, but population health management, if you look at the population as a whole and you look at all the different influences that are there, then you can't say anything else than it is a complex system. We do not know yet, maybe in 25 years of time we say, okay, it's complicated and we understand all the causes, all the inferences that are happening within that population. I don't think it will, but you never know. Right now, we do not understand everything what's going on there. So a simple cause-effect relation, causal relations are very difficult if you look at population health management. That makes it also very difficult for business cases. That makes it very difficult for business cases. So you need learning health systems instead of, I say, business models. Work in progress, we do work in progress, but a lot of work is in progress in the whole area of population health management, on specific populations, on small parts of the whole cycle of the learning health system, of the cross-domain business models, the alternative payment models, if you like, on the regional governance infrastructures that we need. A lot of work is going on there, scientifically, a lot. But does it work? Do we have the proof that it works? Because if we want to go to policy, or if we want to go to the CEOs of big companies, and do they need to step in? They want to see proof, they want to see evidence. My first reaction is always, what's the evidence of the current system? Where do you think you find that? Also to the ministries, etc. The ministers, etc. And our current minister in the Netherlands, she's not a fan of this. She wants to stay at where she is right now. Okay. Does it work? We see the Nuka health system in Alaska is, I think, one of the very few examples that shows that if you do a complete system transformation with a lot of oil dollars, but if you do that in Alaska, then you see together with a large proportion of the native population as well over there, you see numbers as I show on that green slide. Does it work? I think it works if you are able to do that. Please take notice of Singapore. Singapore is now in the journey of a top-down modeling population health management throughout the whole country. So the 5 million people living there and the whole healthcare system is steered in the way of population health management. Take a look at that. Are the numbers already there? No, of course not. It's a learning experience. It's a complex health system. It is not a value-based health model that we can show in 3 years' time that it works. It is a learning health system. What I think is very interesting also to look at is what some of the accountable care organizations in the US have done. Some of them really took up population health management, like the Geisingers and the Kaiser Permanentes, but also the Veterans Administration for already a long time, also some new ones. They took up the ideas of population health management. They start working with it. We're contracted by their health insurer for that. Medicare, Medicaid are all on that same page of population health management right now. So have a look at what's happening there. The evidence is fragmented, also over there. Some regions show promising results, others see no differences with traditional way of organizing and working with populations. To be honest, I think there's another very important problem over here. We have to deal with old school methodology, but also old school outcomes. We are comparing these kind of systems as it were only on cost or only on small health indicators. Whereas for a population, other things are important. What is their experience? We know that subjective health status is the most important determinant of early dying, of dying early, of low life expectancy. We know that. But we do not compare our populations on subjective health status. So I think there's a problem in the evaluation methodology about how should we do that. Well, circumstantial evidence is supportive. We see a lot of narrative. We see a lot of a policy that's going that direction. So there shall be at least something right in this approach. But we're not yet there. So there are some challenges for implementation. Somebody talked about that this morning. We need to connect data specialists and healthcare improvers. If you take it a little bit more at an abstract level, the data specialists have the capabilities of performing population health management. They know how to do it. The healthcare improvers, the professionals or the networks over there, they are in the decision context of what to do. That combination between the data specialists and the people who decide what to do in the surgery room or for that specific population needs to be made. We need to convince care professionals of the importance of the work data specialists can bring them. I don't know if you've ever seen already an example where we pay for health instead of paying for care. Everybody is paid within healthcare for delivering a service. But nobody is paid for the population is being more healthy. In fact, at least in our country, our health insurers are punished if the population is more healthy. Then they get less money the next year out of the total budget. So within the whole system, we need to start thinking about how do we incentivize every actor in their role. And this bullet is especially for you. Do you have a willingness to change, or do you want to stay in your vested interests? I'm comfortable. It will last my time. Next generation can take over. I'll do my best for where I am now. If you do not believe it yourself, or you don't have the willingness to change yourself, it's not going to happen. Don't wait for Berlin. We are here in Berlin, that the government, I always say The Hague, because the government in Holland is in The Hague. But don't wait for Berlin to come with the solution. As you saw this morning, it struck my mind. I'm a political scientist. You know what policy is? Policy is always the crystallization of that what's going on in the society, and they're always behind. And that's logic. That's logic. So if you don't start moving, it will take longer. And we need for learning health systems versus economical business paradigm, business case paradigm. I talked about that previously. And then especially for the sick, we saw that beautiful slide of the different healthcare organizations, where we as the Netherlands and Germany are in the social insurance system, and we have a real problem of implementing population health management, I think, because you need to organize that joint accountability, whereas we have by law divided it towards different actors within the field. And if we keep dividing that accountability by law, and it's very hard organizing. So yeah, then it's logic that an NHS or in a US system or a Singaporean system, or it is more possible and it looks easier to organize it. If we look into our own systems, a payer has a different role than a provider, has a different role than a consumer or a patient or a person. Okay, take-home messages. Population health management is more than a buzzword. It's not equivalent to other concepts. It has a lot of similarities, but it's not equivalent. It has some essentials. It focuses on health and whole populations. It has those specific data features. The uptake in the market is growing. Old school evidence is fragmented. And vested interests make the change very difficult. Those are my take-home messages. And one advertisement slide for our own summer school on population health management, where Nicole has been last year. That's why I'm here now. We have a Master of Science on Population Health Management, which is international. So that's it for now.
Thank you, Marc, very much for your very exciting talk. And I think there are a lot of things which worth to be discussed. And over the last decades in the German Managed Care Association, we were several times thinking whether we should change the name of the association. And then we decided it's much better, in a sense, to take a very broad understanding of managed care. And we would, in a sense, consider population health management fitting perfectly into managed care. But that's one point where I would like to go into the discussion with you. You mentioned, and something which I liked a lot, you said the momentum. I think that's something is very, very important to look, when is the time right? And it doesn't matter whether it is the one or the other concept, but in a sense, the feeling to say, why should it come now? Something which could have come 20 years ago. In the same, when you look, in a sense, the rationale of the story is, and you mentioned it's coming out of the 70s, so it's a long, long time ago that it could have happened, but why you are convinced now it's coming? That's this typical hockey stick effect where it's going down and down and down, and then you believe, no, it's going up. Where's your belief coming from?
My belief is coming from that we understand that we have to get off of the one-size-fits-all. I think that too many people understand that the differences within populations are not well addressed right now with the current concepts. We make one concept for a whole, and we try to transpose that to other situations. Whereas evidence is growing that it doesn't work the same way in different populations.
Absolutely.
So then we start to think, okay, we have to come up with some kind of concept that addresses those differences within populations. And then the old concept came back from, oh, wait a minute, we do have a concept in which we look at differences within concepts, within populations. And to take a small side step, the whole evidence-based medicine movement draw us into the one-size-fits-all. And which brought us a lot of less practice variation and stuff like that. Absolutely fine, we needed that as well, but now we see the momentum is coming because we see that we...
I hope so. When you think about a city like Berlin, how many populations are in Berlin? How would you measure that in a sense? I mean, certainly you would not say Berlin with 4 million inhabitants is one population. How do you make it?
The scalability of population health management is a big issue, as it was in integrated care as well. The scalability, how big should your area of service be? How big should your population be? There are examples that they do it on 20,000. There are examples that they do it on 600,000. We don't know yet. We don't know yet. But we have to look at burning platforms within populations. And if you look at Berlin, then 4 million inhabitants, I think you have at least 10 to 20 burning platforms in specific populations. Do you cover then the whole city of Berlin? No, you don't. Do you have your angle points where you have to go for? Yes, you do. You do.
We would like to have the lecture as an open discussion, and I know there's certainly a lot of questions to Marc, or remarks in a sense to go to this discussion. It is indeed a discussion which fits perfectly to the discussion we have in the German legislation right now with the Gesundheitsregionen, where nobody has a clue what is the right size, how do you want to do it, how do you want to communicate it. And I like very much your example with Ali versus Marc, because nobody would dare to do the same comparison here. And we have, in a sense, to learn also to communicate how differences are and to deal with differences in a healthcare system which believes very strong in the solidarity approaches, which makes everybody same, which obviously is wrong. But the question is, from a health policy perspective, how do we get it managed? How do we get, in a sense, the specific need for a specific population also communicated? And we saw very well in the discussion of the German Gesundheitskioske, it was a perfect case how you could smash a great idea. In a sense, you have first to have a wrong name, wrong people talking about it, wrong payer, and in a sense, something where everybody would say, this makes so much sense, how you could perfectly smash it. But I would like to open the floor for discussions, remarks. Victoria, for example.
Of course, but I was volunteering. I'm not going to open up this question around population health versus integrated care, but what I would like to discuss or ask you about is this question around vested interests. We have been talking about we need to change for the past 20 years at least. There have been tens of thousands of pilot projects in Germany and in all over Europe around care integration, care coordination, transitional care, whatever. And everybody agrees that we need to change. But still, in the end, when it comes down to the actual work, very little has changed. So basically, how do we break those vested interests?
Somebody said something? Please use your mic, because I'm a little bit deaf. Also, syndemic again.
As long as we stay with legal questions and the government has to decide, then the lobbyists will always be stronger than we as patients. Our interest is different. So we should ask ourselves, who is we? Who is starting the innovation? And so we have to organize it or give the freedom to come up with initiatives which organize it in a better way.
Is your thought on it?
I said at the fourth bullet of the challenges, I spoke to the audience. And the vested interest is all in ourselves. And if we are not able to start talking about our own vested interests and that they have to shift, that we have to open up, and if you earn already $100,000 a year, the euros you have, I would say Deutschmark, but that's long ago. Euros, 100,000 euros a year or 70,000 euros a year, that's enough. Then you can start changing. You don't have to be afraid for your job and stuff like that. But that's what we first, because a movement doesn't start, a change doesn't come from above in our kind of societies. It always comes from the bottom. And I think the professionals, and I know a lot of doctors always get angry with me if I say that, but the doctors are the ones who started sick funds. The doctors are the ones who started to kill the epidemics in London with the suing plumbing stuff, etc. So if they don't stand up and say it should be different, then our politicians are never going to change and if they make a bond together with the consumer organizations or the patient organizations, you have even a stronger voice. But I know that a lot of doctors think that's not my responsibility. I'm a doctor. I'm not a kind of social worker or a politician or whatever whatsoever. I know they react like that, but then we stay in our vested interests with ourselves. Look at the website of Rethink. Rethink is a community in the US, started by Donald Barrick as well. And I would say, look at their website and see how they talk about how should you empower and emancipate the current leaders in a different way that they show that they want to change. And intrinsically, every doctor wants it. Because that's why they started.
Lutz, when you think about the strategy of the German Managed Care Association and you follow the speech from Marc, what are your thoughts on it? How does it fit into the strategy of the German Managed Care Association? And how practical could that be implemented in the German healthcare system?
Well, I keep saying that for years, population health management is the future, because it's really the way of taking health a perspective not only on healthcare but on health, and that's something that I put some emphasis on this morning. We're not talking only about healthcare. We're talking about ourselves. We're talking about the way we live our lives, and then health is one instrumental, pivotal part of that. And population health management is the tool to bring health and the force of good health, dealing with health into the midst of our societies, our communities. So I fundamentally believe it's a great concept and it's empowering. That's what we really need, empowerment from patients, from healthcare professionals, and from all stakeholders who want to create better communities. And so my question, or my answer to what is the right size for population health management is where the action come together. And where the people come together, and it can be different sizes, it can be different places, it can be overlapping, it can be different tools. It's just an ocean of opportunities, and this is also where I like to connect to value-based care, which in my sense is really a kind of a twin idea. But I do agree that value-based care needs to be developed to the level where population health management already is. And I like to talk about the value ocean. The ocean of value that we have within healthcare and that we still can use when we talk about things such as population health management. And to come to the end of it, this is why we put so much energy and focus on regions in Germany and care on regions. And we're saying the same thing. We're here in Berlin, but the solution will not come from Berlin. It will come from the people who take the future into their hands.
And I think it's one very important thing, which you also said, it doesn't matter how you name it. The only thing which counts is in the sense that you change it, you do the right things, whether you call it population health management, value-based healthcare, or whatever. It's about the content, what's counts. We have time for one last question. Please indicate also who you are.
Boy Elias, Copenhagen Institute for Future Studies and Robert Bosch Academy. So thank you very much. Sadly, I missed the first 5 minutes. I work quite a lot on preventive health approaches as well. And I really appreciate your part here. There's one point I feel is missing a bit in the bottlenecks. So the average person is actually asking for medicine and knives. They're not asking for health. So a huge part of the driver of change and change in the political will is actually changing the voters. Do you have an opinion on that?
Yeah, I do.
What a question as last question.
Which actor I say it in English. Zorgde ervoor dat, took care of that people are asking now for medicine and knives. Did the people invented medicines and knives? Did they ask for it? Why is there so much advertising from medical companies? Do people ask for it? Or did we brainwash them? And if we brainwashed them, and that's my opinion, then we can also brainwash them the other way. You see, there is no vested interest in medicine and knives for a population. There's interest in health. And we let them believe that their health is being supported by medicine and knives. That's what we are doing. And I'm part of that as well. Eh? So blame me as well. But blame all of us then. Because that's what we are doing.
Yeah, thank you so much, Marc.